Alrighty, good afternoon. I'm pleased to introduce Dr. Jeff Ardell from UCLA, where he's been the director of the UCLA Cardiology Center of Excellence since 2014. Previously, he was at the Quinlan College of Medicine in Johnson City, Tennessee. He received his doctorate from the University of Washington. Dr. Ardell has been a leader in the field of neurocardiology for the last 3 decades, with research interests focusing on interactions and control within the cardiac nervous system. This foundational work has laid the groundwork for his current research in the application of neuromodulation to novel targets in the cardiac pathway. Dr. Ardell is currently the director of several multidisciplinary grants spanning several institutions and has served on multiple national research and advisory committees. He's an outstanding and supportive mentor, training innumerable students throughout his career, and I feel very fortunate to include myself in that category. Today he'll be talking about his work on the application of neuromodulation for the treatment of cardiac disease. So please welcome Jeff Ardell.
Thank you, Tina. It's a real pleasure to be here. Case Western is almost becoming a second home since we've got 3 R01 grants with you guys. So it's been a real pleasure to do with it. I feel real privileged to work with people here and look forward to the continuing collaborations that will develop over the next few years. By way of disclosures, this is the NIH funding awards that we have. Private sector funding from Cybernetics LivaNova, consulting with LivaNova, and a co-founder of a company called NuCures, which is leveraging some of the technologies we've evolved for control of the cardiac nervous system. As a way of setting up this talk, first thing I'd like you to appreciate is on the far side of the slide, you can actually see a graphical representation of how the cardiac nervous system is actually set up. We have the most fundamental of these circuits, which is the intrinsic cardiac nervous system, which is located on the heart itself. It's about 20,000 neurons. It includes both afferents, efferents, and local circuit neurons. The efferents include both sympathetic and parasympathetic neurons, and this actually is the most fundamental of the cardiocardiac reflex control circuits. Superimposed upon that are reflexes which are controlled at intrathoracic extracardiac ganglia, including the stellate middle cervical ganglia, an additional control mediated by the spinal cord, and then afferent input to the spinal cord and brainstem, which is involved in central nervous system control of the cardiac nervous system, involving both the brainstem and higher centers. What I'm going to be doing today is talking about 5 fundamental concepts for structure-functional organization for cardiac control and neuromodulation. We will deal with each of these in sequence. You'll also notice on each of these slides there's appropriate references, so if you want to go and look further into this line of investigation. Now this slide here basically represents about the last 35 years of my life. Heck of a note, you can put 35 years of your life on one slide, but this pretty much encapsulates it. This is the intrinsic cardiac nervous system, where we've identified the expected parasympathetic postganglionic neurons. We found sympathetic postganglionic neurons, local circuit neurons, which represent about 80% of the neurons on the intrinsic cardiac nervous system. This is essentially the processing centers, and the afferent soma, which feed directly onto this. If you transplant a heart, you actually take this nervous system with you, so you really never have a denervated heart. You have a decentralized heart. Superimposed upon the intrinsic cardiac nervous system is the same type of reflexes up in the stellate middle cervical ganglia, where we have, once again, the sympathetic postganglionic neurons, the local circuit neurons, which are the processors, and afferent feedback, which then go into the thoracic cord, which they're also then interact with higher centers, and with major inputs also coming from peripheral chemoreceptors and arterial baroreceptors, either in the aortic arch or over in the carotid sinus. What I hope you appreciate as we go through this talk today, it is the interplay between all these different levels of the control that ultimately determines what happens down at the heart itself in terms of what its electrical and mechanical function is. First of all, to prove to you that they are those types of neurons. Our initial work from the early 80s through the early 2000s, we basically used single electrodes, single microelectrodes which had high impedance, and we could record maybe 3 or 4 neurons at a time. What you see up here on the top left is an example of an intrinsic cardiac nerve recording. You can see electrocardiogram, left ventricular pressure, and the neural activity. And what you basically see is that at this point here, we touch down at the apex of the heart. Now, the important thing about this is this heart was actually disconnected from all higher centers about 6 weeks previously. So that reflex is actually strictly a cardiocardiac reflex. You see the brisk activation of the afferent activity. What you see on the next figure over here is the expected parasympathetic responses. We stimulate the parasympathetic preganglionics, and you can see an evoked response on that intrinsic cardiac neuron. And to show you there's also sympathetic neurons, we activated the sympathetic projections, got an evoked response, and we blocked that with hexamethonium. Same thing can be applied to the interthoracic extracardiac ganglia, like the stellate middle cervical. Once again, we have the efferent neurons, which are sympathetic, local surrogate, and afferent neurons. Now, the way we have moved away from that single recording is we've gone now to multi-channel recording using these plunge electrodes that you can see inserted here into one of the ganglionic plexuses on the heart. They tend to be located in fatty tissue. This one here is actually located at the right atrial ganglionic plexus, which basically is associated with control of the SA node. And what you can see is we can actually record multiple unit activity from this area. And what we do is we do a whole series of different types of stressors. We touch the heart, we stimulate the parasympathetic and sympathetic inputs, we do transient ischemias, we do occlusions of the great vessels, either the inferior vena cava aorta, or we stimulate nerves on the heart, these that are very important for communicating between ganglionic clusters. And what you can see, first of all, is there's a great diversity in the responses. The green circles here, the green colors represent increases in activity, and the red indicate decreases in activity. If these neurons and ganglia were function as relay systems, those should all be the same, but you can see a diversity. You can also see that some neurons only respond to certain types of stress. For example, this neuron here only responds to touch of the heart and a great vessel occlusion. Or an LAD occlusion. Others respond to both mechanical stimulation and electrical stimulation of the autonomic nerves. Taken together, what we've done is we would basically define these neurons as either afferent neurons, which means they respond to great vessel occlusion, ischemia, or touch, or efferent neurons, which respond to activation of the autonomic inputs to the heart, or convergent neurons, which respond to both mechanical and electrical stimulation of the autonomic nerves to the heart. We're also able to identify specific temporal relationships between the cardiac cycle and the neural activity. There are some that are activated during the systolic phase, some which are activated during the ejection phase, and some that really don't have any activity, and those are indicated over here. The long and the short of it is that afferent neurons, this is a conditional probability curve right here. If you respond to a mechanical stimulation of one type, you usually respond to more than one of those. And same thing for the autonomic nerve inputs. And what you basically see is they all converge on the convergent neurons, which respond to all types of stimulation. The other thing that we found is that if you look at an individual ganglia, you should not think of it as a specific ganglia for a specific function. Like, for example, there have been some people which have tried to call this ganglia here, which is the right atrial ganglionic plexus, as the SA nodal ganglia, and this one right here is they call, which is the inferior vena cava inferior left atrial ganglia, as the AV nodal ganglia. The reason we say that's not the case is if actually you go in and do microinjections of nicotine into each of these ganglia, what you're going to basically find is that you're going to find substantial changes in large areas of the heart. Regardless of if I'm injecting into atrial ganglia or ventricular ganglia, which you see up here, you see that a large part of them cause changes in atrial rate. A large part of them cause changes in AV conduction, and some of them also induce atrial fibrillation. So what this basically indicates is that within these ganglia, there's also interconnections between different clusters of the ganglia, and this forms what we call the intrinsic ganglionic plexus. These neurons also, as we've talked about, are primarily local circuit neurons. There is a great deal of common shared efferent inputs and afferent feedback to this system. Now, the other interesting aspect is when this actually, if you would think back in the history of this institution in Cleveland, this is a figure that Matt Levy would have just absolutely been thrilled about. This basically shows that if you stimulate the vagus here, you get a prompt decrease. This is not the best laser in the world. If you stimulate the vagus, you get a prompt decrease in heart rate, which when you stop the stimulation rapidly returns. If you go over here and you stimulate the sympathetics, you get a nice increase in heart rate. You turn on the parasympathetics at the same level, and it comes down to about the same area right here. Matt called this accentuated antagonism. What it basically means in response to combined sympathetic and parasympathetic stimulations, the parasympathetic system predominates. When you stop that stimulation, you get a rapid return back to the pre-vagal stimulation levels. Matt, for the most part, Dr. Levy pretty much attributed this to interactions at the myocytes themselves, but what we basically found is just as follows. We actually went in and surgically ablated this right atrial ganglionated plexus here, and you can see an example of it up here before and after the ablation. What we basically found is after we take out that ganglia, we get no change in atrial rate when we stimulate the vagus, which is in marked contrast to what you see with an intact condition. Now, what was exciting for us is if you go to the next step here, and we just saw this figure over here, here we have now stimulate the sympathetics, heart rate goes up, parasympathetic stimulation is turned on, and we actually restore that heart rate right back to baseline. And when we take off that stimulation, it goes right back. If you give atropine, what you basically do is you get no bradycardia on top of that sympathetic mediated response. So what this basically means is that even though you are not seeing any evidence of a direct parasympathetic input into the SA node, we still have predominant autonomic interactions taking place within the ganglia. So what that means is don't think about autonomic interactions at just one level. You have to think about it at the myocyte level, at the ganglia level, and higher up. Now, the other thing that happens is this system, sometimes I call our field Zen cardiology. The field usually is, the system is really quite happy when all the inputs are in sort of a homogeneous situation. They're coming down and they're getting feedback and everything is in good shape. If we go down and disturb the system by going in with a small bipolar probe and stimulating within certain of the mediastinal nerves on the heart for short periods of time during the atrial refractory period, we can induce periods of short duration atrial fibrillation. These characteristics of this atrial fibrillation is they have a latency of about 1 second and they have a duration of about 30 seconds. The beauty of this is a model which is reproducible all day. So if you're interested in understanding pharmacological or neuromodulation type approaches for treating atrial fibrillation, this is a great model. And you see here that we induce the atrial fibrillation with 4 bursts during those refractory periods. To prove to you this is neurally mediated, this is a response here where you see 2 bursts induced a period of atrial fibrillation. If we gave hexamethonium to block those nerve projections, you can see we stimulated for 20 seconds and could not evoke that atrial event. Now, taking the same process which I talked to you previously about with the microelectrodes going in, what you see here is an example of all the different neurons we identified within the intrinsic cardiac plexus, within the right atrial ganglionated plexus, in response once again to the touch, the great vessel occlusions or the sympathetic and parasympathetic stimulation as compared to atrial fibrillation. And what we basically found is that if you induce the atrial fibrillation, there's a large increase in activity. And if you actually subdivide the types of neurons which are activated, it's primarily the local circuit neurons which show the predominant increase in activity. Interestingly, if we then do a neuromodulation approach, which is right cervical vagal stimulation for 3 minutes, and then we do a reevaluation, we can see now if we do the same type of mediastinal stimulation, there's little or no increase in activity. If you look across the board, you find that the activity is primarily reduced in that response in the convergent neurons with some effect on the afferent neurons. And more importantly, what we find is we get a 75% ablation or attenuation of the atrial arrhythmia potential. This is very exciting for us. Now, the main drawback is this is preemptive. We have tried to use the same approach in an atrial fibrillation which is already established, and it was not effective. But that is not necessarily bad if this, as we'll see in a few minutes, we have ways around that. What we've also asked the question is, what are the characteristics of the network function when you have these periods of atrial fibrillation? You can think of it in terms of an electrophysiologist's point of view. You can sit there and say, well, it's a whole bunch of excitable foci within the intrinsic cardiac nervous system, which is going out and inducing the substrate for atrial fibrillation. Or you could get essentially a little neural rotor which is going on, which is reinforcing each other. To look at that, what we did is we did correlation analysis between the afferents, the afferent efferents, afferent convergence, efferent efferent, efferent convergent, convergent convergent. What we basically found is that in the process of going into atrial fibrillation and during atrial fibrillation, we primarily found an increase in correlation between the efferent to convergent neurons and the convergent to convergent. So it's really a recurring circuit within that neural network which is producing the atrial fibrillation. And as we saw in the previous slide, if I essentially damp down the convergent responses, the potential for that atrial fibrillation goes away, as does the circuit reinforcement. The other nice thing about this is it has memory. So what you see here is an example of a short period of vagal nerve stimulation, and then looking at what happens for up to an hour and 20 minutes afterwards. And what we basically find is the mitigation of atrial fibrillation actually has a time constant of about 30 minutes. So what this basically means, if I want to put my subject into a state of reasonable cardioprotection against atrial fibrillation, I just have to deliver vagal nerve stimulation for 2 or 3 minutes every 30 minutes. So we actually do have a way of dealing with a case where we have a patient who is going into long-standing atrial fibrillation. All right. The next concept I'd like to deal with is concept 4, is there are inherent and acquired factors that impact the progression of cardiac disease. All right, this is an example of what happens when you have a short duration myocardial ischemia. This is about 30 seconds of a myocardial ischemia, and we're recording from one of the principal sympathetic neurons, ganglia, in the heart, in the intrathoracic cavity, which is the middle cervical ganglia. And what you can see is rapidly with the onset of myocardial ischemia, you get a large increase in activity within the sympathetic postganglionic neurons. And here's the histogram chart up here, and you can see a very pronounced activity that maintains itself during the occlusion, then on reperfusion, it goes back to baseline. Now, when I say there are inherent differences in the autonomic nervous system, this is a primary example of what happens. What you see here is an example of what happens to interstitial catecholamines when I do, in this case, a 15-minute myocardial ischemia. And what we're doing is we're actually sampling from the interstitial fluid using microdialysis and analyzing the catecholamines with radioenzymatic assay. This study here, this data slide you see right here, took almost 18 months to generate all the data from because of the time course it took to do the assay. We could do 50 samples a week at a cost of $600. The reason I point this up is Dr. Smith out in the audience, in collaboration with us and his team, have developed a new technique with fast-scanning cyclic voltometry that could give us this same data in minutes. So we're really quite excited about that collaboration. But let's getting back to the main point I want to do here. What you see here is animals are subdivided into animals which fibrillated or those animals which were able to sustain that 15-minute ischemic event. What you can see as follows is the animals which fibrillated had a greater release of catecholamines during the ischemic event and a big burst of catecholamines on reperfusion, and the animals went into ventricular fibrillation. The animals which did not show that surge were able to tolerate that event. So we call this our rule of threes. If in this room all of us had the same heart attack, 1/3 of you would be dead, 1/3 of you would survive that event, but on the next ischemic event would be succumb to that with sudden cardiac death, and the remaining third, my finger's getting tired. Thank you, sir. That's better. The remaining third, you could hit them with a freight train and they're going to continue to live. So you guys, just before you have any pathology, there are differences in your system. One of the challenges for us in the field of neurocardiology is to identify those biomarkers which are predictive of that pathology. And the reason for that is as follows. All right, so we decided to figure out, well, what is the main conflict within that reflex processing that's resulting in our potential for sudden cardiac death? So what we did is, this is once again the entire neuraxis that we talked about. So what we decided to do was compare animals that had a fully functioning nervous system with those in which we disconnected the projections from the spinal cord into the stellate middle cervical ganglia, versus those where all interconnections between the intrinsic cardiac nervous system and the rest of the heart were essentially interrupted, and compare that to a final group which used spinal cord stimulation, which was applied to the high thoracic cord. The whole idea was to sit here and say, how does each of these processes interfere with the response to the myocardial ischemia? Now, classical thinking would say, if I disconnected all the connections from the spinal cord to the peripheral ganglia, I should have had no sympathetic response. What we found was quite the opposite. On the top figure here, you see the example of what happens in the normal ischemic zone and the midwall in between in response to the ischemic event. You can see in all three areas, a marked increase in catecholamines with the ischemic event, which continued into the 1 minute of reperfusion. When we disconnected the central nervous system from the interthoracic ganglia, what we found is we still got a catecholamine release, but it was reduced by about 20 to 30%. This is important because what this indicates is that there's actually afferent feedback from the heart, which can feed to the intrinsic, to the stellate ganglia and middle cervical ganglia, and still give us a reasonable but more balanced sympathetic response. If we then compare that to a group where we cut all connections, neural inputs to and from the heart, and just have the intrinsic cardiac nervous system, you'll see that the only place we get an ischemic induced catecholamine release is within the ischemic zone itself, and this could either be a cardiocardiac reflex or the result of the ischemic event. Thing that got us the most excited about this is here is the death curve for the animals that had intact neuraxis. Once again, about 1/3 of them did not sustain that insult. And after we did the decentralization, either of the stellates or the intrinsic cardiac nervous system, that death rate, the number of animals lost, drops to only about 8 to 10%. So you go from 1/3 potential for sudden cardiac death to less than 10%. All right. Now, obviously, most of us are not going to go in and have various nerves cut to our heart. There are other ways we can go about it, and this follows up on some work we've been doing for a number of years with spinal cord stimulation. What we have found previously with spinal cord stimulation is this is actually a technique which was evolved over in Europe initially about 25 years ago for treatment of angina, especially for applied to patients who had angina which was not amenable to go in and for revascularization. And basically we've already determined that it has important influences on ganglionic processing and on cell death. What we determined here is if we looked at the amount of sympathetic response to this and catecholamine response to this ischemic, here's the normal response, baseline to occlusion, and this is when we have the response down here in terms of the occlusion with SCS, and you can see no change in activity. If you actually look at so that was direct neural recordings from the middle cervical ganglia. If you look at the catecholamine release within the ventricle, you find that this is the expected response in the normal ischemic zone with intact innervation in the presence of SCS. That is reduced markedly, and once again you'll find that the survival potential for these animals is much improved. This is nice because this is an on-demand stimulation. It can actually be done chronically in these patients with very little difficulty. The main thing that it's got me sort of sad is that over in Europe, where this used to be done extensively for angina, it's actually falling off the radar, mostly because of insurance companies and governments are not paying for the procedure. So it's a real benefit to patients which is not being developed, and certainly something you guys should certainly consider as you move forward developing new interfaces. Now this sort of summarizes those data, which basically indicate with a full neuraxis you get a full amplification of sympathetic nervous system of about 152%. If you disconnect the central nervous system, that's reduced down to 14%. If you look at just the intrinsic cardiac nervous system, it's 16%. And if you look at spinal cord stimulation, it's reduced by over 2/3. This paper, by the way, has just got accepted in JCI Insight and is available online. All right, I'd now like to talk about the concept of acquired factors that impact the progression of cardiac disease. The reason I do this is because there are important changes which take place in your afferents, in your ganglia, and in your efferents, which actually determine in total what influence the cardiac nervous system has on the heart, and effectively what happens to the progression of heart disease. Now, this is some work which we did back just as I got to UCLA. And what we did here is we recorded from one of the ventricular intrinsic cardiac ganglia, and we looked at various characteristics of these ganglia. This work was done by Pradeep. He was an MD PhD student, which was working with me, and he's now back in medical school. But what we basically found here is if you look at the size of the neurons, they get bigger. If you look at their neurochemical profile, it changes. The chat decreases, tyrosine hydroxylase goes up, the VIP goes up. To show to you this is a pretty substantial insult, here's a porcine ventricle. You can see the scar area. If you look at the MRI, you can see the pronounced scar area down here in the apex of the left ventricle. If you go in and you look at the response to touching sensory fields within the heart, you'll also find changes. What you basically find is if you touch in the areas of the scarness and border area, you basically find a marked reduction in sensory input. If you touch in areas outside the scar, you get a maintained or slightly increased activity, and this creates a sensory border zone. Now, why is that important to you? If you think about most of neurophysiology, for example, like vision, if you get areas of contrast, that tends to be one of the most predominant signals for activating efferent responses or neural responses. So by having this abnormal structural area within the heart, you actually create a markedly increased sensory output, which actually drives higher centers to remodel. That is also reflected in what happens in terms of the neurons which receive sympathetic and parasympathetic and sympathetic input, which are the convergent efferent neurons, and you can see the number of those actually doubles. So what this means is that the nervous system on the heart is also reorganizing in response to this stress. If you go in and look at the conditional probability type stuff, you can see in a normal condition that there's a great deal of interconnection in this network response to various types of stressors, be it great vessel occlusion, be it touching the heart, be it pacing, be it stimulation of autonomic inputs, and that this results in an overall balance of responses to maintain coordination of electrical mechanical function on the heart. Once you get into myocardial infarction, what you find is the system becomes a lot more loosey-goosey. The correlation between neural populations was reduced. That results in a high potential for heterogeneity in output, and that sets up the substrate for excessive autonomic outputs and results in a major component of progression into heart disease. Now, the other interesting fact is if you think about heart disease, especially heart failure, the hallmarks of heart failure are that sympathetic nerve activity goes up and parasympathetic activity goes down. That doesn't mean your parasympathetic system isn't structurally there. If you actually go in and look at the amount of catecholamines within this area, it's essentially normal. If you go in and stimulate the vagus to the heart, you can actually see quite normal changes in electrical properties of the heart, which is here defined as activation recovery interval. And what that basically says is structurally the parasympathetic nervous system is maintaining itself, but something has happened to the central drive. And that has important consequences for therapies we're going to talk about in a few minutes. All right, so if you talk about the concepts for conclusion 4, you have to understand that the intrinsic cardiac nervous system undergoes both morphological and phenotypical changes after myocardial infarction. The same can be said for the stellate middle cervical ganglia. Afferent signaling from this system changes, and this creates the neural sensory border zone. Convergent neurons become enhanced, and the functional interconnectivity actually is reduced. Overall, this results in sympatho-excitation and withdrawal of parasympathetic cardioprotective influences. All right, this gets us to the part which hopefully you guys will find the most interesting, and this is how do you start leveraging this information to do effective neuromodulation. Effective neuromodulation, as we're going to talk about, is dependent upon the interface, where it's placed, and how you stimulate. You do it right, you're going to help your patient. You do it wrong, at best, you're not going to help him. At worst, you could actually hurt him. All right, so what are our targets? The targets for neuromodulation strategy for cardiac disease are either to the aberrant afferent signaling, restore parasympathetic tone, or reduce the sympatho-excitation. And we're going to talk about each of these in more detail. All right, let's talk first about afferent transduction. All right, with afferent transduction, if you have an ischemic event, what happens is the area which is in the ischemic field is not going to beat as well. There's going to be acidosis in that area. And there's going to be essentially changes in the interstitial environment in both the mechanical and electrical, which is going to result in a significant increase in activity as you activate the nociceptive receptors within that receptive field. The heart is sensing something is going wrong, and unfortunately, our cardiac nervous system is not set up to deal with that type of signaling. It actually can result in catastrophic effects. And here you can see here when I do the occlusion, I get activation of, in this case, nodose afferents, which are those associated with the vagus. You see a nice increase in heart rate. All right, what we decided to do was to look at both dorsal root ganglia and nodose ganglia in response to various types of neuromodulation. The two we decided to use were vagal stimulation and spinal cord stimulation. And let's look first here at the responses of dorsal root ganglia neurons, which are the sympathetic afferents. And you can see here in the sham treatment a pronounced increase in activity, which is maintained into the reperfusion phase. And you can see in the presence of spinal cord stimulation that there's a reduction in activity. There's really not much of an increase during the ischemic event, and it goes even further down during reperfusion. If you average and summarize all that data, what you basically find is a significant drop in the activity of the dorsal root ganglia sympathetic afferents in response to the stress. Same thing goes on with the nodose ganglia. Over here we can see that ischemia is very excitatory. You can see that right here in this figure right here. After we do vagal nerve stimulation, that response is markedly attenuated. So excitingly for me was when we did spinal cord stimulation, we also caused an attenuation in that response. So both direct and remote neuromodulation can have an impact on afferent transduction. What is the commonality between these two? The commonality between these two is what goes on at the heart itself. When these neural inputs come in and are activated appropriately, what we've demonstrated is that there are changes in the myocyte, likely related to changes in substrate utilization. And what that means is when you have an ischemic event, that heart is in much better shape to withstand that ischemic event. That does not mean we're creating silent ischemia. Silent ischemia is something you'd never want to create for your patients. If I take a patient who has a spinal cord stimulator and I put him on a treadmill and I exercise him to a level without spinal cord stimulation, he will go till he gets ST segment elevation, he experiences pain, and the stress test will stop. If I have the spinal cord stimulation, we can take that treadmill to higher and higher levels, but when his ST segment starts changing, that is basically at a much higher level of exercise. So he's been able to tolerate that without damage to the heart. So that's the case of indicating one form of neuromodulation is on the myocyte itself and on the myocyte neural innervation. And now we're going to talk about other influences, other levels where that can take place. For those of you who don't stimulate the autonomic nervous system, here is a very nice example of what happens when you stimulate a vagus. What you see is a prompt decrease in heart rate, which is maintained during that stimulation. After stimulation off, it returns promptly to control. You can see a decrease in the contractility, which is the DPDT, and a resulting decrease in blood pressure from a decrease in cardiac output. So this is a very typical response to vagal stimulation. The interesting thing that happened here, which was very surprising to me, was what happens when you disconnect where you're stimulating from higher centers of the cardiac nervous system. This is an example of what happens when you stimulate from 0 to 3.5 milliamps on, in this case, the right vagus in an intact innervation. And what you can see is at low levels of stimulation, this I think was at 10 hertz, we got an increase in heart rate, and as we get to higher levels, we got the expected bradycardia. When we cut the nerve, the vagus nerve rostral to that point, look what happened. No longer get the tachycardias, but we now get an exaggerated bradycardia. And if we cut both vagi, heart rate goes up because of the loss of central parasympathetic drive. But now look what happens when you do that same vagal stimulation. We actually reduce heart rate almost down to 0, about 90%. What this shows is that as you stimulate on that cervical vagus, you're activating both ascending and descending fibers. And it's the integrated response to that determines your final response. Sometimes I refer to this as push back. It's really just a function of a multi-level negative feedback system which is responding to perturbation. But here you can see that same concept. If you stimulate the vagus, initially a tachycardia, then a bradycardia, by the time you cut both neurons, you see that curve is shifted to the left almost a factor of 10. Same thing holds to the left vagus. The other interesting thing that came out of this is there was always a long controversy. If you stimulate the vagus, does it even go to the ventricle? So if you look at DPDT, you can see with an intact innervation, hardly any change. When you cut all the nerves, you can see a very pronounced decrease in that contractility. So this demonstrates bilateral projections to the ventricle, and this demonstrates the impact of stimulating afferent and efferent fibers on integrated function. Now that was an anesthetized case. Obviously, we're interested in what happens in an awake animal. So what we did is we implanted vagal stimulators on both the right and left vagus in canines. We kept them around for about almost 2 years. We did all kinds of stimulus response curves on these animals. And what you see here is an example of a VNS at a very low intensity, very little change in the sinus arrhythmia. Going to a little bit higher intensity, you see the tachycardia during the on phase of that vagal stimulation. Going to a little bit higher level intensity, you'll see essentially a flattening out of the sinus arrhythmia during the on phase. And going to a little bit higher level, you see the expected bradycardia. Now, if you spend a lot of time on this and generate all these different points, going from 0.5 to 3.5 milliamps, 2 hertz all the way up to 20 hertz, what you basically find is as follows. We found that stimulating at very low pulse widths of 130 microseconds, very little change in heart rate. If we increase that pulse width up to 250, you can see the tachycardia phase that we talked about, and a very nice bradycardia during higher levels of intensity stimulation. And that if you go to 500, you don't get much change in that. You go to 750, you're not change in that. So basically, we determined that just by stimulating at 250, you can achieve almost full control, and that essentially doubles your battery life on any implantable. The other thing we found is we found what we call the neural fulcrum. This is the area as defined by an area where you really don't get tachycardia, you really don't get bradycardia, but you're essentially fully engaging both the ascending and descending parts of the nervous system. And the best analogy to that, if you think about having a 2,000-pound weight in a room, just a flat room here, I try to push it, I can't do it. If I put it on a vibrating table, put a little bit of inertia into it, I can push it across the room. Same thing with this neural intervention. If I stimulate it where I'm at the fulcrum and I'm actually engaging both levels, it's very easy for me to have bidirectional control of this overall neural network. The other interesting thing about this is we also were obviously worried about if you did this VNS and you put in standard of care for heart failure, would you interfere with it? When we gave metoprolol or enalapril or avapridine, you can see we get essentially the same response. If you did give an acetylcholine blocking agent, the glycopyruvate, you can get rid of the response. Well, this basically indicated that under normal treatments for heart failure, we could essentially put the VNS on those patients and still be in good shape. Now, before we moved to the patients, we actually did some preclinical studies in the guinea pig. We also did it in the canines. And what we basically did is we used 2 models. One was the pressure overload, which we produced a 20% constriction of the descending aorta, or we did a myocardial infarction by tying off the left anterior descending artery. and we followed these animals. And what happened is 10 days after the insult, we started the vagal nerve stimulation at either 20 hertz, 1 milliamp, 4 milliseconds on, 48 milliseconds, 48 seconds off. And what we found was as follows. We found that the potential for apoptosis was reduced within these hearts with the myocardial infarction, and we also found that ejection fraction was much better maintained in these animals as a result of that. What was more exciting to me was the data we got from the pressure overload models, because this is a model of preserved ejection heart failure. This type of heart failure is pretty much unresponsive to all the traditional therapies we have out there. And there's really not a whole lot of options for these patients. And what you can see here is we produce the pressure overload. You get the expected hyperdynamic cardiac output response as you try to maintain perfusion of the periphery. You get the dilation in the systolic and diastolic dimensions of the ventricle. And what we found is if we started vagal nerve stimulation 10 days after we did this, we prevented that hypertrophy. We prevented the hyperdynamic cardiac output response. So essentially, by just starting this neuromodulation at a certain period of time, we were able to prevent the adverse remodeling of the nervous system and of the heart tissue itself. If we actually took it down to the smallest level, where we looked at the intrinsic cardiac neurons, that we would go in here, do intracellular recordings, we'd stimulate inputs in here. And if you look more importantly here at the pressure overload model, you can see that here's the normal in response to the pressure overload, a dramatic increase in following frequency, which means an increase in sensitivity of synapses within the ganglia. And if we did the VNS, we restored that down to control. So not only did we change the myocytes in terms of their responses to stress, we also prevented the adverse remodeling of the autonomic nervous system. Now, where did we take this? The reason I got involved in this was because back in 2013, there was a big interest in using VNS for reduced ejection heart failure. There were 3 companies that got really excited about this. One was Medtronic, one was Boston Scientific, and the other was Cyberonics. By way of disclosure, I became the scientific advisor for Cyberonics. What they basically did is they had very different approaches. All right? On the Nectar study, they put in a stimulator on the right cervical vagus. They stimulated at a duty cycle of 17%, 10 seconds on, 15 off, 20 hertz, and they initially planned to get up to 4 volts in terms of their stimulation. What they basically found when they did that is they ran into off-target effects at 1.4 milliamps, which was the cough, the GI discomfort. They couldn't take their patients up any higher. They continued the study at the 1.4 millivolts, and the long and the short of it, the study failed. The patients didn't show any positive benefit except in things like a little bit of some of the walk tests and some of the quality of life. All right? The Innovate trial, which was the one done with the CardioFit system, had a very different approach. What they did here is they had a right cervical vagal nerve stimulation, but they also had blocking technology in it. Their idea was if they blocked the afferents, they could stimulate the vagus a lot stronger, but they only did this at the cardiac cycle. The net effect of that is, for me, that's not a very effective strategy because, first of all, you're not close to the intrinsic activity of the nervous system. And second of all, just the activity of interrupting the afferents is a destabilizing influence, as you saw from the previous slide. This study also failed. Anthem was our initial pilot study. We did this was based on the principle of the neural fulcrum, which was at 10 hertz, went down here, and we basically, these patients did overall very well. The reason, when I say get to the neural fulcrum, as I told you, the Boston group couldn't get up there. What we basically found is if we trained the vagus to vagal stimulation by stimulating its shorter cycle lengths initially, which is 130, we could actually up the current, then we could step up the pulse width, and we actually got to a point where we could train the vagus, both right and left, to that stimulation, and we could basically stimulate wherever we wanted. And this shows you where all those studies fell on that evoked response curve. The Nectar basically ended up with their patients here on the tachycardia range. The CardioFit Innovate study basically put themselves on a very flat part of the curve, which my analogy is it's like driving a car on an icy lake. Neither your brakes or your accelerator work very well. And the anthem, we utilized the concept of the neural fulcrum. Now, what we basically found from all of this is as I talked about, is if you looked at the differences between the anthem, innovate, and nectar, is basically we found significant improvement in the various parameters of the both ejection fraction and in terms of indices of heart rate, of stability variability. Importantly, when we went on to this, when it was taken out to 42 months, that whole process actually maintained itself very well. The FDA actually found this data so compelling that we are now in the process of doing the Anthem pivotal trial, which is now in enrollment, and I think we have 150 patients already enrolled in this, and we're really quite excited about moving forward with this. And getting back to the concept of mechanistic-based science, just think what the FDA was faced with. They just saw two major, Boston Scientific and Medtronic's, fail in clinical trials. Why the heck were they going to approve another clinical trial with VNS? When we showed them the mechanistic data and understanding, they gave us the go-ahead for the accelerated pivotal trial. All right, I'm going to switch gears now. We've talked about the sympathetic nervous system. I'm now going to talk a little bit about how do I modulate the sympathetic nervous system in terms of this control. And what this is an example here, this is a human paravertebral chain right here. Let me give you a little background on this. About 12, 13 years ago, a patient came into the emergency room at the Reagan Hospital. His implantable cardiodefibrillator was discharging about 10 to 15 times a day. He was getting burns on his body from his discharges, and they were running out of options to do. What do you do? He didn't respond to the drugs. His ICD was going crazy. They actually put a catheter into his spinal cord, and they did spinal anesthesia. Within a short period of time, that patient's arrhythmias went away. Now, you're obviously not going to have a catheter in that patient for a long period of time, giving him anesthesia every few hours. So what they decided to do was switch over to the technique of stellectomy and stellate decentralization. And what they did is actually they surgically go in and they take out the bottom half of the stellate down to the fourth thoracic ganglia of the paravertebral chain. And what they basically found is they did it both left and right. If you did just left stellate decentralization, basically 12 months out, you had a shock-free thing of about 0.4, which means that 6 of the patients still were getting a shock sometime during that month. When they did bilateral stellate stimulation, basically you'd see that a year out, only 25% of the patients still receive a shock. So this was a real benefit for these patients. The reason they did the left stellate stimulation was primarily based on some of the work that Peter Swartz did back in the 80s, which had some fundamental problems with it. When we actually looked at the concept of going to bilateral and did the science, this made a lot more sense, and you can see a huge benefit for our patients. But the main problem with this is irreversible. All right, so we said, what can we do to make this into a reversible process? And this is where my collaborations with Kevin's group and Aloy and Tina came into play back, about 3 or 4 years ago. All right, first thing we determined is where are you going to apply blocking technology to? And what we basically did first was we went in and we looked at the sympathetic distributions from the paravertebral chain, and we basically determined that the majority of sympathetic inputs come into the paravertebral chain, go up that chain to the stellate ganglia, out through the ansa subclavia, and down to the heart. So what this identified for us was that this T1, T2 area was a critical nexus point where we could control sympathetic nervous system to the heart. And this basically shows as I cut those projections, I get rid of the control. And what we decided to do was, well, can we start putting blocking technology in this area? We actually did 2 different types of blocking technology. One was with the kilohertz approach, and the other one was with a modification of the DC. The kilohertz approach, Aloy has leveraged into a grant, and the DC, Tina has just leveraged into a grant. So 2 studies have become very effective in moving forward. I'm very excited about this and looking forward to continuing collaborations. But what Tina did for us is she brought to us this carousel DC electrode. And what this basically means is if you use a DC block, basically if you try to maintain DC block at any one node for longer than about 12 seconds, you start to create the environment that destroys the nerve. So that's not a good thing. The way Tina figured out to do this as part of her thesis was she developed the carousel, which basically means you just go from one node to another node to another node to another node. And here's a single node, and if you interlace those nodes together, what you can see is you can maintain block for a very long period of time without damaging the nerve. What did I do here? All right, so here's an example of when you put the DC block on in either a reactive or a preemptive mode. So here's an example of sympathetic stimulation. You start stimulation here, you can see a nice increase in heart rate, a nice increase in left ventricular pressure, a nice increase in contractility. At this point, you put on the DC block and you can see a decrease in heart rate, DPDT, and pressure, which is indicative of what you'd see if you stop the stimulation. And when that DC block went off, you got to return back to normal. So this was an area which was very appropriate for doing, to essentially stop that, to reduce that activity. When you put it on the preemptive mode and start the sympathetic stimulation, you can see very little response, but when the DC block goes off, a very robust response. So this basically showed in either a reactive or a preemptive mode it was equally effective. What we next showed was that it was scalable. So this shows the DC current versus changes in heart rate, changes in DPDT. And what you basically find is that these are individual animals, that what you can do is you can personalize the response for any animal, going from a full-blown response to a complete block depending on the current that you use. And the important thing is the application of that current had very little effect on basal cardiac function. So you're not compromising cardiac function, but you're preventing sympathetic outflow from that area coming in an abnormal way. And what we then next did is we then created our infarct model. Here's an example of the infarct model we use. This is created by putting a catheter into the left anterior descending artery, injecting microspheres, producing a substantial damage downstream from essentially ischemia, which goes into an infarct. There's the infarct right there. And here, here's an example. You can see there's an angiogram before we did the microsphere injection and afterwards, and you can see a large area which is hypoperfused. If you go in, and then what we did then is then we established the block, in this case, just on one side. And we actually chose the side which should have had the least effect, which was on the right side. Left side has a more predominant influence on ventricular projections into the area of interest. We chose the right side. And what we did is we actually set a block which is with a level of about 60 to 70% of normal, of ultrasympathetic response. And lo and behold, when we did the overall response, we found that all the animals were inducible before we did the block. So what do I mean by inducible? We bring the animals into the laboratory, we do program pacing, where you basically give a series of 8 normal shocks, or 8 normal pace things, and then you give a shorter pace. You keep going till you get to the refractory period, you add another one. It's called the S1, S2 protocol. But basically all these animals we could actually put into ventricular tachycardia, ventricular fibrillation. In the presence of the block, we were only able to do that in one of the 7 animals. Not only that, the ventricular effective refractory period went up. Why are we excited about this? This actually is a way where we could replace implantable cardiodefibrilators. Right now, cardiodefibrilators go and sense an abnormal or rhythm coming on, and they sit there and then they give a shock to get out of it. This case, which we haven't implemented yet in terms of a chronic condition, if you start to eliminate that abnormal event, you could actually put the block on and essentially get a high degree of cardioprotection without having to give a shock. You would obviously have to have the defibrillator circuit still in place as you start doing it as a fail-safe, but this is a way to move forward to get rid of a shock. I don't know if you've ever had any friends that have had the implantable cardiodefibrilators. In a sense, it almost produces a state of post-traumatic stress disorder, because they're always sitting there worried about when they're going to get a shock, and the shocks could be quite debilitating. So what have we come from all this? Progression of the cardiac disease involves both the nervous system and the heart. Traditional therapies like ICDs, ablations, or drugs really haven't progressed much in the last 20 years. And neuromodulation-based approaches at these appropriate exit points, which are delivered with a firm understanding of structure function, really are the future for cardiac therapeutics, and we're very excited about it. Obviously, I can't do all this myself. This is the very talented team which we have assembled at UCLA, headed by Dr. Shiv Kumar, who's head of the Arrhythmia Center. I direct the research arm, and just an incredible talented group of people, some of which are in this room, like Jasmine Kipke back in the back, who came and worked with us for 2 years. Just so much fun and so many good people, just like the people we have here. And we look forward to continuing collaborations over the coming years. Thanks very much.
Questions?
It's a Thursday afternoon. Yes, sir.
So I'm pleased to hear that your study is going into a pivotal trial. But broadly speaking, the history of autonomic stimulation, the translation from animal models to clinical models, has been poor.
Yes.
And I'm just curious, you've done an enormous amount of mechanistic work. I don't want this to be such a softball question. Is that the reason that your study is succeeding? What do we need to do better to increase the rate of translations?
Is you need to understand the neural circuits you have put your interface on. You need to understand what happens to those circuits when you do the stimulation, and you need to understand it in the context of plasticity. When you understand all those factors, you're able to do it. None of the neuromodulations are going to be set and forget. It's just like if I'm giving a pharmacological intervention to a patient, I'm not going to give them the same dose for the entire time. You need to understand what you're doing, how you do it. I mean, the reason that Nectar and Innovate failed was because of a very poor understanding of the systems they were trying to control. The reason that Defeat HF failed with spinal cord stimulation was because when they did the clinical design, they only stimulated the patients 12 hours a day. The maximum memory you have on an autonomic nervous system after a neuromodulation event is about 30 minutes. So would you give a drug to a patient that covers them 12 hours a day? I mean, it isn't a softball question. I think things fail because people, in a rush to get their technology to clinical evaluation, don't have a full understanding of what they're doing. And I think it's contingent upon those of us in the room and those of us in the field to educate these people and to make sure they go forward. For example, the Anthem trial totally changed its stimulation protocols based on the first 2 months of my work with the Vegas. So they actually totally revamped their protocol, and that's why it went forward as it did. But like I said, the other thing that I consider is that you can't cure every single pathology with a single intervention. I think you're going to need to understand what that pathology is and what's the best place to do it. Is it spinal cord stimulation? Is it vagus? Could you get by with just doing the tragus stimulation? We don't know. I mean, that's where we're going. What I can say is that the level of interest and excitement and support in this field is actually just skyrocketing, especially in the last 5 to 8 years. Starting off with DARPA and GSK, and now continuing on with the SPARK program from NIH. So it shows a great deal of promise. Various of our colleagues, both here and at other institutions, are showing very nice efficacy in cardiac in GI pathology and some pulmonary events. So it's a very exciting time. And you've got some of the best investigators in those fields at this institution, which I've had the pleasure of interacting with.
A lot of the effects of the extrinsic innervation seem to be negative, at least in some of the examples you showed. Is that a general, is that a more generalizable cause of disorder?
What happens is, I think that the patients who are at high risk for pathology are those who have hyperdynamic and heterogeneous reflexes. They're the ones they tend to get. It's sort of an autonomic type A personality. They respond to excessive levels, and those are the ones. The other thing too is you got to be careful. Like for example, if you are doing things where you go into a high degree of stress, you need to make sure you just don't stop that stress quickly. You need to be smart enough to warm down from those. But certainly, like I said, as I said, if I could predict who were the third that were at the highest risk, we could put on interventions today which could reduce their risk substantially. We don't have that biomarker yet, but we're hoping to get to it.
Sort of a semi-related question was, you said that transplanted hearts have their intrinsic nervous system.
Yep.
Do they ever get reinnervated
Yes.
from the extrinsic nervous system?
Yeah, actually and the fun thing about that is you don't have to innervate the whole heart from that one point. You've got to remember this entire intrinsic network essentially is interconnected. So just like a power grid, all you got to do is make a contact into a part of it and you've established control over a large area. We found the reinnervation as early as 1 year.
So in that last study you mentioned that you innervated one side of the sympathetic chain and that side had the least amount of innervation to that
No.
section of the
But
heart?
what we did is if you use the Peter Schwartz analogy, he always said left stylectomy should be good, right stylectomy should be bad. So we actually to stack the cards the most against us to see how efficient we could be, we went after the right side bad and we found right side good. Now we don't believe right side bad. We think that both sides can be manipulated appropriately. But actually, if you look at some of our papers from patients with, for example, long-standing ventricular tachycardia, when we do the stylectomy on them, you look at those stellates. There's substantial changes in neurochemical phenotype. There's immune responses in them. They're really quite deranged. And so the whole goal here, and we actually have other lines of investigation which I didn't talk about today to indicate that most of that derangement is afferent driven. So when I talked about those three targets, modulating the afferents, modulating the sympathetics, modulating the parasympathetic, those are all viable targets.
Yes, a question about the stimulation of the vagus. The vagus is mostly afferent fibers. So you think the effect is through the efferent fibers that go to the cardiac area, or you think it's a reflex through the afferent fibers?
Well, I think most of our data indicate that when we do the lower intensity stimulations, we start getting afferent activation at currents half of what the efferent activation thresholds are. So we think a large part of the initial increases in heart rate are because of decreases in central drive of the central parasympathetic, with some potential interactions with the C1 area of the spinal cord and modulation of the sympathetics. And then as we get to higher levels, then we engage the parasympathetics. So it's really, you're actually doing an opposing effect. You're getting a central drive which is still going down some, but you're actually increasing the direct exogenous control of the vagus. So that's when we're at the fulcrum is when we're at a balance between withdrawal and activation. And like as the work with you're doing, like you said, is we're also doing some of that work with the Holder group over in London. I mean, can we get to a thing where we can get to specific fascicular stimulations and actually get a much better control without having any of the off-target effects? We are involved in that as you are. So.
And I'm still not clear. Not three studies you showed. It seemed like the amplitude was pretty much the same for all three, but one you said had a lot of side effects and it couldn't continue, and the other two you don't get any side effects. Even
Here's what. Okay, so let me explain that a little bit better. If you are at 20 hertz and you were at a long pulse width, which for me is 500 microseconds, or even 300, if you start increasing the current, what will happen is that you will reach a point where the patients will start having cough, they'll have vocal problems, they'll have GI discomfort. What we basically found is if we went to a lower frequency and a much lower pulse width, we could actually step that current up to 3.5 milliamps within a couple days. And then we could step up the pulse width, and then we could step that current up again, so we could actually get into the neural fulcrum. If I didn't do that titration curve ahead of time, the conditioning protocol ahead of time, we would have never got there. So that was the advantage over that. That's sort of a fun story on that one. is these initial 6-month reports were done at the European Society for Cardiology a number of years ago, and they were already reporting negative results. And I actually went up to their scientific team and I said, here's how you can fix your study. And they basically sat there and says, no, we're fine. And they went ahead with it. And then when they finished the study, they went back and actually used some post hoc analysis, and they basically determined that only in 10% of their patients had they achieved any degree of a control of the vagus. So 90% of their patients were essentially placebo. So take home story, understand what you're doing. Oh, getting back to your question once again real quick. When we switched our protocol to that short duration stimulation, I can get up to type 2 clinical efficacy within 10 days. If you try to do it with the old-fashioned way, like they've done with epilepsy, it takes them 4 to 6 months. So there's a real advantage. I'll talk to you more about it tomorrow when we do it.
It was very great presentation. My question is on atrial fibrillation. So the commonest risk factor for atrial fibrillation is hypertension, high blood pressure. So how does it interact with you think the intracardiac ganglia becomes hyperactive? What's the mechanism you think is?
Sort of an interesting point on that. What we actually did a model with a renal wrap with silk, which caused an increase in blood pressure of about 50 millimeters of mercury on our animals. It's not a rigid capsule it forms, it just is a little irritant there. And what we basically found on that was that the parasympathetic responsiveness became exaggerated, but there was no central drive. The sympathetic system actually lost efficacy with time. And when we reinstated vagal stimulation, what we basically found with that is that we restored sympathetic responsiveness, we brought the parasympathetic system back towards normal, and the overall contractile function of the animals improved markedly. So the whole trick is when you do vagal stimulation, you're having a whole lot of influences. You're having an anti-adrenergic effect, you're changing the abnormal afferent signaling, and you're essentially putting a governor on the reflexes, so even if they respond to stress, they don't have hyperdynamic responses. So overall, if you sort of put a chill pill into the patient with the vagal stimulation, they actually do much better.
One more question I have on ganglia. When you destroy the ganglia, does it grow back like the nerves?
Which ganglia?
Intrinsic
If I surgically take out its stellate ganglia, it's not coming back.
No,
but on the
intrinsic
intrinsic, if I go in and lesion it with radio frequency or something like that, what basically happens is that ganglia doesn't necessarily come back. There's about 20,000 neurons on the heart. What happens is because of the interconnectivity and sprouting and reorganization, you essentially can regain control of a specific area. So I've never been a big proponent of combining the ganglia ablation along with the substrate ablation in heart rate and for arrhythmias. I'm a much bigger proponent of doing strategies which engage the entire network and actually bring it back to a more normal state.
Thank you. It's a very, very, very nice talk, for us. And I just wanted to know about the heart, which you said that around 20,000 neurons are there, and I'm sure they are not homogeneous and homogeneously distributed.
Huge heterogeneity.
Yeah. So while you are doing stimulation, do you look for any particular kind of neurons there?
Well,
and how do you identify them?
When we do our network analysis, what we basically find is when we stabilize the local circuit neurons, the system does much better, both in terms of heart failure and arrhythmias. So those are the populations that we really like to target. I can't turn my stimulator and say, okay, this is the optimum stimulation for a local circuit neuron. But what we do know is when I do the stimulation appropriately, that's the population I'm preferentially impacting to exert a positive effect. If I do a destabilizing influence, that's the population when it gets destabilized when I have adverse effects.
So any specific biomarker, how to identify those effective neurons?
You figure that out, and you figure that out, and I'll buy you a dinner.
Target that.
No, I mean if you go in and do the immunohistochemistry of the intrinsic cardiac nervous system, you find some neurons which have the expected cholinergic profile. You find some neurons which have many aspects of an adrenergic profile. And you find large numbers of neurons which have both cholinergic and adrenergic profiles. And you have a whole other set which are defined as non-adrenergic, non-cholinergic. So this is still very much a major interest of ours. If I had to say our biggest change now is we've gotten away from thinking about individual neurons like I showed you here today, and we're actually focusing much more on using microelectrodes where we're getting large numbers of activities and focusing much more on network dynamics. And that's, I think, is going to tell us a lot more than the single unit stuff that I've done for the last 30 years.
Okay, well,